Hello and welcome to this very special show. Elekta presents Transforming Healthcare, Improving Lives, partnered by Times Now. Now, in every walk of life, we've been impacted by digitization, by technology. Things have improved vastly, and specifically in the medical space, technology has transformed our lives greatly. Today, I have a panel of experts, and we're going to talk about how a certain new technology is helping improve cancer care. First up, allow me to introduce my panelists. We're joined virtually by Dr. Kevin Brown. He's a distinguished scientist. He's the inventor of numerous patents, and he's received the Member of the Order of the British Empire in recognition for his contribution to radiotherapy. Dr. Brown, thank you so much for joining us. We have also with us Dr. Arjun Sehgal. He's MD, Chief of Radiation Oncology at Sunnybrook Health Sciences Center and Professor of Radiation Oncology at the University of Toronto. Joining me in studio, we have Dr. Dilip Gudipudi. He's Senior Consultant Radiation Oncology at Yashoda Hospital, Hyderabad. And also I have Mr. Manikandan Bala. He's the MD India and Senior Vice President at Elekta. Gentlemen, doctors, thank you so much for joining me. Mr. Bala, let's start off with you. I spoke about technology, and this is this new technology called MR-Linac. Can you tell me a little bit about what this is and why is it being called a game changer?
We all are aware that the cancer incidences in India are rising and rising exponentially. So there is an urgent need for us to start addressing this huge cancer burden in our country. One of the main solutions to this is increase access across the country. And this would require increase the number of linear accelerators across the country, for example, and the other treatment modalities. Equally important is the urgency to improve the care, the precision radiation care amongst the cancer patients. 50% of the cancer patients would require radiation therapy at some time. Unfortunately, that percentage is hovering around 20% in India. So we would require access and the care or precision care to be improved. And that is where an innovation like MR-Linac comes in. MR-Linac is a combination of MRI imaging, which is a gold standard in soft tissue imaging, and a very powerful linear accelerator.
Okay, great. So simplifying it for our layman, because the audience, I'm sure, knows what an MRI is. But how is the linear accelerator? What is it? How are both of these being combined? If you could just shed some more light on that.
Sure. So as you rightly pointed out, MRI, magnetic resonance imaging, has been in technology on the diagnostic side for a very long time. On the radiation side, linear accelerators have been in use for a substantial period of time, and the next generation linear accelerators have been precise in even treating the tumors, the cancer. Having said that, the existing or the present generation of linear accelerators, while technologically advanced, still have a challenge when it comes to live imaging. And that's where magnetic resonance imaging with the linear accelerator combined addresses the issue of live imaging, which results in adaptive therapy and comprehensive motion management, which we can discuss in detail.
Fantastic. So that's really important. And I'll now move to Dr. Brown to get you in on this, to take this ahead, because I mean, it's obvious that the doctors would want to be looking at that part of the body that they are treating. So why did it take so long for MR-Linac to come across?
It's a very challenging problem to make an MR and a linear accelerator operate near each other. And when this project was first proposed, many people thought that it would be impossible for us to put these two technologies even in the same room. But through a number of very smart innovations, we've managed to separate the operation of the MR and the linear accelerator so they can both coexist. And that means that you can then use the MR images to actually guide the radiation to the right place in the patient. So that's the first time we've been able to use that level of imaging to guide the treatment to exactly the right place.
And I'll come back to you on that, Dr. Brown, but I'll just move to Dr. Sehgal now. So you've been using this technology for a while now. Just what's been your opinion? How's it been used there? What are some of the results? What's the feedback?
We've been actually developing this technology initially for brain tumors. And what we can see now for the first time is the actual tumor changing during treatment. And because we have an MRI taken right before we actually shine the radiation on the tumor, we can start to adapt it. And we can start to adapt it weekly and even daily so that we ensure that we always hit the target. And as we gained our comfort in brain tumors, which is an organ which doesn't necessarily move, but the tumor is actually changing throughout the brain, we've adopted the technology to prostate cancer, and now one of the most difficult tumors to treat in the body being pancreas cancers. And this is really where we want to further develop the technology, change outcomes for the future of patients, because a tumor in the pancreas is surrounded by all of these critical organs, like the duodenum. And that limited our ability to deliver high doses of radiation to essentially ablate the cancer. And now we can actually use that technology, shine the radiation optimally to the tumor, and make sure that we're always hitting it despite the tumor and the pancreas moving. And that movement happens with normal physiologic motion in the body. So we've taken this technology to many different areas within the body to perform what we call adaptive radiation, and always ensuring that we're hitting the target because we can actually see the target.
Dr. Dilip, and also to you, Mr. Bala, I want to come to you for a minute more on the India area. And first to you, Dr. Dilip, what are the major cancers the common kind of cancers that you're seeing here in India and that you are more treating?
So most common cancers would be the head and neck malignancies, the oral cavity, the pharyngeal cancers, then followed by lung cancer, which is the highest actually. Then you have the prostate, which has jumped into the third place, especially in men.
Yeah.
And then you have stomach cancer and then other cancers. But if you go to women, it is breast cancer followed by cervix, then you have ovary, endometrium, and then they have lung. So breast is in a huge number. It is already 2 lakh cases per annum is what we are seeing. Okay. So once you try to accommodate more and more patients on the treatment, then shortening the treatment time is what we require. Because conventionally it was 5 to 6 weeks, came down to 3 to 4. Mild hyperfraction is what we call.
Right.
Now with the fast forward trial, which came out, it's 5 fractions. So you're able to accommodate more patients if you're trying to do, and then MR would help us in this aspect.
Mr. Bala, your thoughts also on this. How are you seeing? What are some of the major cancers that you're seeing, and just your thoughts on how this will help those specific ones? No,
again, as all the experts here opined, we do have substantial spread of these cancers, especially the breast, the cervix, the oral cancer, and colorectal cancer as well. As we move forward, we need to find ways of personalizing the treatment across all these. We have moved from a stage where one size fits all to a stage where we need to really customize it to every individual, and that's where the adaptive radiation therapy combined with personalized medicine really works in favor of these patients.
That's a very important point you brought up, Mr. Bala, and very important to be noted. Dr. Brown, I'll just want to bring you back in the conversation. Where do you see this technology going in the future? How do you see this technology developing in the future?
MR is a very exciting imaging technology. As we've already explained, we can use the MR every day the patient comes for the treatment to see the cancer, to see the healthy tissue around that we want to avoid, and adapt the shape of the radiation so that it exactly conforms to what we wanted to do on that day. And what we're going to do is we're going to use that real-time MR processed automatically by the computer to turn the radiation beam on and off, whether the target's in the right place or not. And in the future, I think the radiation beam will be moving to follow the cancer, a bit like, I hesitate to use a military analogy, but a bit like a guided missile tracking a target that's actually moving. Our goal is to deliver accurate treatments in the same way that the military do with their guided missiles as well. And the next thing, which is also very exciting, I think, is what we call biology-guided radiotherapy. And this is where we use the MR to actually measure the individual patient's response to the treatment. And then we can incorporate this information into their treatment regime and improve it even more, we hope.
On that note, it's time for a very short break here on Elekta Presents Transforming Healthcare, Improving Lives, partnered by Times Now. Don't go anywhere. We'll be right back. Welcome back to this special show called Elekta Presents Transforming Healthcare, Improving Lives, partnered by Times Now. I'm in conversation with a panel of experts. We have with us Dr. Kevin Brown, Dr. Arjun Sehgal, Dr. Dilip Gudipudi, and Mr. Manikandan Bala. Mr. Bala, I'm bringing you in now. You know, obviously we've spoken about this technology. It's very different. It's changing the game. How do you think this will complement the existing linear accelerator technology?
Great question. So as we discussed briefly, adaptive radiation therapy and the comprehensive motion management is the way forward. And we will see a lot of progress in that. Having said that, the linear accelerators which are in play right now have their good role to play as well as we move forward. India is fortunate to adapt this new technology of MR-Linac very fast. In fact, India is one of the few countries which have adapted it very early. The linear accelerators which are existing have their own role to play. MR-Linac at this point of time will be focused on specific treatment manifestation of cancers. And as time goes by, adaptation is going to be much more towards the MR-Linac. Having said that, as this technology gets adapted, we also will need to have the skill development parallelly going, because it is not just the technology, it is also the people behind the machines, right? So we are already proactively training and developing the skill set around usage of this technology so that we can get a lot more adaptation going forward across the country.
Yeah, that's a very important point you brought up, Mr. Bala, because it's not just about the machine, but it's also about the man or the woman behind that machine to be able to run that machine properly. So that's, yes, a very important point there. Dr. Sehgal, coming to you, I just wanted to know your thoughts on whether you think this technology, is it being used optimally? And what's your opinion on the potential of this technology, MR-Linac?
Well, I think we're early on in terms of the development. We are applying the technology to try and improve our outcomes in terms of reducing toxicity and improving the chance of cure for some of these cancers. But the road ahead, as Dr. Brown mentioned, is coming forward and very quickly. So just like we personalize a cancer management based on the genomics, what this machine and this paradigm of MR-guided linear accelerator therapy will do is allow us to personalize the radiation to that patient's tumor. And that's the exciting area. So together with the genomics, together with advanced radiation delivery, we can really make a difference for the future. And that's why it's a game-changing technology for the entire world.
I'll come back to you, Dr. Sehgal, but I'll just reach out to now Dr. Dilip. So you're using this in India. Can you bring in the India context to this? I know you've been using this for just a couple of months now, but what's been your feedback? What's been your experience? Can you shine some light from the India context?
The thing is, you're able to see the tumor, which is very important because you'll not be able to see the X-ray. Okay, so our initial experience is since the start for the clinical use from April, we have completed close to 715 sessions of radiation. We have completed around 36 patients for the treatment, and currently 14 patients are undergoing therapy. What we observed is during the adaptation, and then there is a real-time MRI which happens when the treatment is occurring. So one of the prostate case, when we are doing a live workshop, he was passing gas through the rectum. So the prostate displaced anteriorly, and suddenly we have to stop the radiation because the rectum is coming into the field of radiation. That patient was planned for something called SBRT, very high dose of radiation in short duration. So you're probably the normal organ is in the field of radiation, you're going to damage it.
Mm-hmm.
So at a click of a button, you can stop the radiation, wait for the gas to pass, again start the treatment. So the real game changer is while treatment is happening, you have a real-time MRI which is occurring during the therapy, which we can monitor.
Yes.
And this is like the last mile for the radiation oncologists. Initially, we plan at the start of treatment, we are there and we hand over the patient to the technologist and then supervised by the physicist. And whenever required, we go. But this technology, the radiation oncologist has to be at the console while the therapy is happening so that you understand better what is happening intrinsically, because human body is dynamic. What we are planning is on a static scan, but what is happening while therapy is completely dynamic, and then you're able to monitor it. So minimize the toxicity.
As we wind up, I just first want to come to Dr. Brown and Dr. Sehgal. Gentlemen, you're working internationally and you've been working in different parts of the world as well. Your thoughts on this technology, your experiences abroad that you think would be very important for people, for doctors, as well as for patients, as well as our viewers in India to take note of, to be aware of? Any insights that you can share with us?
Internationally, we've grown as a consortium, so a community of experts really trying to understand how this technology applies to common cancers. So all of the founding members of the MR-Linac consortium really enabled the treatment paradigms for cancers such as brain tumors, prostate cancer, pancreas cancer, rectal cancer. And so I think India and the entire world can learn from all of that work that we did. And now as the consortium grows to many institutions all over the world, I think the community is going to come together so that we can apply this technology for all patients and understand who needs it and deliver it in a very safe and efficacious manner.
That's very good. I was going to mention the consortium as well, that early on in the development of this technology, we recognized that introducing the MR-Linac into the clinic was going to be a change. And in order for that change to be successful and as effective as it can be, then the most effective way for us to work was to collaborate. And so we formed this international collaboration, which we call the consortium. And there we're developing best practices to make sure that when new hospitals come on board, that they can benefit from the experience of other users of this technology and get it to as many patients as possible, and as highest quality that we can to benefit, make most impact, most benefit into society, really. So that's what we continually strive to do, not just a technology, but also education and a community as well.
Dr. Dilip, just wanting your inputs. When patients come to you for this treatment, are they worried about this new technology? How do you explain this to them? What I'm trying to get to is that, there are a lot of myths that patients have in their minds. And of course, when they go for a cancer treatment, it's just they're more worried. So how do you put their worries to ease? What do you talk to them? What do you tell them?
So suppose if the patient comes with a brain tumor, he's already through the MRI. So he understands why a doctor is ordering an MRI and why, because it helps us to understand where the tumor exactly is, what it is, and characteristics of it. And then when we say that I'm going to use this MRI, and then I'm using the real-time MRI on the machine to track it and then treat, they're like, wow, they're going to see it. So it is exciting because in other linear accelerators where the cone beam CT is what we use, it's very poor quality. I would say good quality, but still it's a gray because of the physics kind of thing, photon scattering. So you're not able to appreciate the tumor where exactly is. So there you rely more on the bony landmarks, and then you use your clinical intuition and experience and then go ahead with the treatments. But when you come to this, then you're exactly seeing is what is happening because you do a pre-treatment scan,
right? Adapt
to it, and then post-treatment, during the therapy, you do an MRI and then track it. So they're very happy. So, and then I can do it for pelvis malignancies like cervix, Okay, for endometrial cancer in the post-op setting, for the rectal cancers, for the prostate, which is primary. So there was a myth that we cannot do MRI for thorax because there will be an artifact because of the breathing, but it is not there.
Okay.
So what, because the MR is so fast in this machine, within 2 to 3 minutes, we'll be able to do that MR and then see very nicely because you have an air interface artifact, which clearly tells us where the tumor is. So that's other advantage what we're seeing, especially when you're treating lung malignancies.
Great. Thank you for sharing that. As we wind up this discussion, Mr. Balajist, your thoughts from our discussion today, some key takeaways that you would like to leave with our viewers.
Okay, let me start with this. A few years back, cancer was regarded as a dreaded disease. It was like a curse on that individual who was struggling with cancer. We have significantly improved that status. We have moved forward. And today, majority of these can be addressed, can be managed. Having said that, the innovation on technology constantly keeps pushing the bar higher. And therefore, for all those cancer patients out there, there's a lot of hope. And this hope is only improving day by day, thanks to all the clinicians, all the expert clinicians we have in this country, and of course, the innovative technology which comes in, which significantly advances the patient care. So, as we say, we just don't build machines, we build hope for all those cancer patients out there. So the future looks great, and the innovation definitely ensures that future continues to look bright.
Well, that's all the time that we have on this special episode of Elekta Presents Transforming Healthcare, Improving Lives, partnered by Times Now. Thank you, Dr. Brown and Dr. Sehgal. Thank you, Dr. Dilip and Mr. Manikandan, for being a part of this special episode. Thank you to the viewers for watching our special show. Our aim on this episode has been to bring to you the latest developments in medical technology and to discuss how treatments are evolving owing to the increased innovation and research in the field of medicine. But do remember, this is not medical advice in any way, so please consult with your doctor before you undertake any medical treatment. Thank you so much for watching.